Everyone, thank you for joining the public listening session on oversight and monitoring in early interventions, evidence-based practices. For questions to our speakers, please use the Q&A feature located on your Zoom toolbar. This call is being recorded. If you have any objections, please disconnect at this time. Without further ado, please welcome Marlise Perez and Michelle Wong.
Thank you so much, Charisma, and thank you all for joining us today for another one of our public listening sessions with our rollout for behavioral health transformation. And we can move over to the next slide. So my name is Marlise Perez, and I am with the Department of Healthcare Services. I am the Behavioral Health Transformation Project Executive, and today with me is Michelle Wong, who is also going to help present. She is the Chief over our Behavioral Health Oversight and Monitoring Division, and also Tracy Walker. She's going to help me read some of your feedback today, and she's one of our key members of DHCS as well. So here is just some housekeeping. I think the most important thing to note that if you are having problems, you see my lips moving, but you're not hearing anything, maybe you need some tech support, you can use the Q&A feature. And then also that's going to be used when we get to the questions and feedback we're going to be walking through. And then just a reminder today, it's really hearing from you. We're going to be presenting some of our draft policy that we're looking at as we continue to roll out all of our efforts around Proposition 1. But we aren't going to be answering questions today, but we'll take them because that really helps as we're developing just all of our policy and also our technical assistance and training. So with that, we can move forward. As I already mentioned, this is to gather information. We're going to present two topics to you today. I'm going to start with the evidence-based practices and CDEP list, and then we're going to move into monitoring and oversight. So after each section, we'll be pausing. We have a question for you, a prompt, and then we'll ask you for your feedback. Next slide. All right. We're going to reiterate this also at the end of the listening session, but maybe you wake up tonight in the middle of the night, you're like, oh, I should have put this forward, or I really want them to hear about this. We'll be accepting feedback through August 7th. That is so we can compile just an overview of the feedback, but if on August 8th you think of something else, feel free to still send it to us. It just won't be in the overall synopsis, but we'll review that feedback as well. And you'll see here it's our BHD info email that you can send that to. All right, so let's dive in. So we are going to start with our early intervention evidence-based practice and community-defined evidence-based practice biennial list. Say that 5 times fast. We can move forward here. So through the legislation that was passed, we're required to develop for the early intervention component of the Behavioral Health Services Act, this EBP and CDEP list. And so you'll see here where it's noted in the statute. We've already developed a very draft list. We are going to be posting that for public comment, and that's going to be within our module 4 that we'll be releasing for public comment in the next few months. And so what today is really going to help once again kind of inform. We're going to talk to you a little bit about how we put this list together. And once again, wanting to hear your feedback on that, we will then submit out the draft, get your comments there as well, and then post the final. So next slide. So with the requirements in statute, this list will be published biannually. So we'll be going through this process with you as we just continue to not only roll out behavioral health transformation, but in years to come. And then we do want to just highlight once again, this list is pertaining to early intervention that falls under our behavioral health services and supports bucket. This list is not exhaustive. It is an optional tool for our county partners to utilize. And that of course will be when the services begin in July of 2026 for BHSA. Now, some of the EBPs or CDEPs on the list contain elements of population-based prevention, which is that, as a reminder, that population-based prevention is being lifted up by our partners at the Department of Public Health. But you'll note there we're still including some that may have some population-based prevention because it is a smaller portion of the EBP, but the whole EBP needs to be delivered together. And we'll talk a little bit about that and how that will work. And then just want to really emphasize that other CDEPs and EBPs can be used in the development of the integrated plan and also as BHSA services roll out. So we have defined, and we'll be putting this out in our policy as well, the definitions of EBPs and CDEPs. And you'll see here the EBPs, these have already been clinically reviewed, codified. These are also, we've been using EBPs from databases, excuse me, and clearinghouses, and you'll see here some of the ones that we've been using and putting on the draft list. As equally important are CDEPs, and these are community-defined evidence practices, and these have reached a strong level of support within specific communities. I want to note that these are often really assisting areas where there may be disparities or very specialized populations. And so we've been looking at lists such as the California Reducing Disparities Project and others as well that have already been, defining out and bringing forward these robust CDEPs as well. Next slide. So how we've been compiling the list, both the EBPs and CDEPs will be listed together, and we really are doing that on purpose to show that they have equal value and importance. The list is gonna be organized by population type. You'll see here on the left-hand side, these are the different population categories that we've been stratifying the EBPs and CDEPs in. They're also going to be addressing mental health, substance use, and then also co-occurring. Once we publish the final list, this is going to be after, can you go back a slide? There we go. That final list will have links to training and other information for each of the CDEPs and EBPs to be a resource for our counties and other partners that are implementing them. All right, next slide. And so after we publish this first list and get that out and finalized, as I mentioned earlier, we will be then every 2 years publishing a new list. The initial list that we finalize and then the ones that we publish every 2 years after will be published in our policy manual. And then you'll see here, this is the process for stakeholders to request a new EBP or CDEP be added to the list. And so this is once again the process that we're going to be utilizing after we have this first list published. Next slide. So these are some of the sources that we've been referencing to develop this first list. Just wanted to show you we've been doing quite thorough research and really reaching out far and wide to see what's already been out and done in the field and seeing what is working across California, but also just across the nation as a whole. And so this information, once again, is just to show you that we've been really doing our due diligence. However, once this list is published, we really want to hear from folks, like if there's something that you also, EBP or CDEP that's not listed that you want us to explore. Next slide. All right, so we are to our first question. Are there other sources, databases, clearinghouses that DHCS should reference when we're looking at updating the biennial list? And if my team could just kind of move us back to that last slide so everybody can kind of see what we've already been looking at, we would love just to hear your feedback in this space. So just as a reminder, if you could put any of your feedback into the Q&A, and then Tracy and I are going to just be reviewing some of it. And just as a reminder too, anything that we don't call out, that doesn't mean that we aren't looking at it. It's just we're touching on a few so folks can kind of hear what everybody is saying. And then also, I know folks will probably end up putting some questions in. If we're able to answer your question just as a clarifying question, we'll do so. Otherwise, once again, we'll make sure that it's clear in the policy when we release that. So we're already getting some feedback. Just in a clarification, just want to remind everybody that this list that will be posted is going to be optional. So a county can still fund other EBPs or CDEPs under early intervention if that is not on the list. Right. Well, we're not getting too much feedback on this first question, which is fine. We're getting, oh, here we are. We're getting a little bit more in here. Just getting a lot of comments in around making sure that another area we might want to look at with UCLA and UCSD. So I know we've done some work with UCLA, but I think it'd be great to look into both of those. So thank you for that feedback. Also some feedback to utilize the Commission for Behavioral Health. Great. Well, we're going to move forward because we have a lot more to present to you. But if you think of other organizations that would be helpful for us to look at, please let us know. That'd be really great. And so I'm going to baton it over to Michelle, and she's going to present the next section. Michelle?
Thanks, Marlise. So I'm actually going to now review our proposed approach for oversight and monitoring policies under BHSA, including reports, compliance reviews, and enforcement. So let's go to the next slide, please. All right, so on this slide, we are previewing the expected outline for Module 4 of the BHSA Policy Manual, which will contain these 4 main components of oversight and monitoring. The first section will have additional detail in the submission and review process for the key BHSA reports, including the IP, annual update, and the BODER. We're going to be building on the policies that are described in Module 3. And then next, Module 4 will describe our process for BHSA compliance reviews, including a preview of our efforts to align compliance reviews across BHSA and other behavioral health programs. I will then talk about enforcement mechanisms such as corrective action plans and monetary sanctions. And then finally, we'll touch on requirements for counties to monitor their BHSA providers for compliance with program requirements. Next slide, please. Because SB 326 largely aligned the statutory authorities for BHSA and Medi-Cal, and because we are seeking to align standards and processes across programs, we are modeling our BHSA oversight policies on existing Medi-Cal policies as much as possible, believing that the aligned policies will enhance efficiency for both DHCS and the counties. This slide essentially identifies those key statutory authorities and existing Medi-Cal policies in each area of DHCS's oversight. Next slide, please. So I'm going to go ahead and start with a brief reminder of our policies on ensuring complete and timely data in the IP, AU, and BODER. These details are discussed in prior modules, but are also relevant for our more general oversight policies. Next slide. So DHCS will follow up with counties if their IP, AU, or BODER is late or incomplete. In addition, we may require substantive revisions under certain circumstances, which we will cover in subsequent slides. Counties will have 15 calendar days to submit updated reports if corrections are needed. And then for serious or persistent deficiencies in reporting, we may require like a corrective action plan or impose monetary sanctions, as with other types of county noncompliance that we will discuss later on. Next slide. So under SB 326, DHCS may require counties to revise their IP AU if we determine that the submitted IP or AU fails to address local needs in terms of both leveraging appropriate data sources and appropriately allocating funding between mental health and SUD services, or if the county has failed to make adequate progress in meeting performance standards under BHSA, Medi-Cal, or SAMHSA grants. As a reminder, DHCS has told counties that Phase 1 BHSA planning performance measures will not be used for enforcement. However, looking ahead, the Phase 2 accountability performance measures may inform enforcement activities. Next slide, please. So before wrapping up this section on reporting, we wanted to provide some additional context about the optional self-disclosures that were built into the IP, and that may also be included in the AU and BODR. Specifically, counties can self-disclose implementation challenges or concerns for certain requirements under BHSA and other programs, notably including the board certification that counties are meeting their realignment obligations. These self-disclosures are optional. They do not require counties to expressly confirm that they're out of compliance. And the goals for the self-disclosures are essentially allowing DHCS to gather data on common challenges, identify priority topics for technical assistance, and develop efficient BHSA compliance review protocols, as I'll discuss in the next section. Next slide, please.
Great, thanks, Michelle. So this takes us to our next feedback question. So what feedback do you have on the integrated plan report content and submissions and required revisions? And so once again, this is pertaining to the monitoring portion. So if you could put any of your feedback into the Q&A at this time. We do have some feedback coming in, and one of it's actually a question, but I can address this about the stakeholder engagement and how that's going to be, since that is a requirement for counties to engage with key stakeholder groups, and how will that be monitored and assessed. And so just in speaking to this, there will be a review process that is conducted by DHCS around the requirements in the IP. And so that will be done during that review process as a part of that.
We have another question that we can answer. If the IP is submitted earlier than March 31st, will it be reviewed earlier? And I will say absolutely. We encourage counties to submit as soon as they're able. And if it's before that date, that would be wonderful for our staff who have to review the IPs and provide feedback.
There's also some feedback coming in around just discussing, since the integrated plan covers all of the behavioral health service funding that the counties receive at the local level, just really asking to align monitoring with other reporting that's coming in, such as network adequacy and triennials. And so just asking the department to take that into consideration. I do just want to state, we have been looking at the department level of just how we are organizing our monitoring, and Michelle's team actually is over now monitoring all of the behavioral health funding sources. So that's one step in that direction. So more to come in that space, but thank you for that feedback. Also, some comments in around the requirements to collaborate with the local health jurisdictions, and how DHCS will ensure and kind of monitor that collaboration happens. Also, some just questions in general about the department once it again kind of reviewing the IP, how long that's going to take, and just concerns in that space, and just some feedback recognizing that those any delays could impact the just the provision of services beginning July 1. So there are some very clear deadline set that we will be releasing a little bit more guidance on in our modular 4, but we have a lot of that already set in our policy manual. But the department and has been working with our county partners to ensure that we can get these plans reviewed and back out if we have any questions to our county partners in a timely manner, so services can start July 1. So back to Tracy's point, the sooner we get those integrated plans, the quicker we can begin those review processes. All right, well, thank you for the feedback here. We're going to move on to our next section, and I apologize we're not able to read everybody's feedback. Doesn't mean we aren't seeing it, but so thank you for that. But I'm going to turn it back to Michelle.
Great, thanks, Marlise. So we're going to go ahead and talk about compliance reviews, and it's broken into two subsections. I'll talk briefly about our plan to align compliance reviews across behavioral health programs, and then we'll talk about BHSA compliance reviews as well. So on the next slide. So we developed a compliance review process. We are considering these opportunities to align compliance reviews across all behavioral health programs, including BHSA, Medi-Cal, and SAMHSA block grants where applicable. And by doing so, we're aiming to avoid duplicative requests for pre-review document submissions, align similar requirements across programs when feasible, and streamlining the review process itself to the extent where possible. So the BHSA policy manual will offer a high-level preview of these alignment efforts, but this process will be supported by separate guidance that we intend to release following stakeholder engagement activities. The policy manual will also focus primarily on defining BHSA-specific oversight processes, which aligns closely with existing Medi-Cal processes. Next slide, please. So this slide shows the progression of review consolidation. Currently, we need to complete 3 separate review processes: triennial Medi-Cal special mental health services reviews, annual concurrent reviews for Medi-Cal substance use disorder services and SABG, and triennial concurrent reviews of MHSA and MABG. For Medi-Cal, DHCS is moving towards an integrated SMHS and SUD agreement effective for all counties in 2027. This will allow for an annual integrated audit. We're also planning to further align our reviews through one annual review for all behavioral health programs. We have not determined yet the effective date for these changes, and we will provide additional guidance in the future, along with opportunities for stakeholder engagement. Though they will not be included in the BHSA policy manual, DHCS has identified some considerations while we plan for consolidated behavioral health compliance reviews, which include county and DHCS staff capacity, training, and organization, and a glide path from current state to future state, as well as defining a reporting period for the aligned review. Next slide, please.
Thanks, Michelle. So leads us to our next question. Are there other aspects of aligning county behavioral health compliance reviews that DHCS should consider? And maybe if my team could just pop us back to the last slide so you can kind of see that chart that Michelle walked us through. Not seeing any feedback yet, and just a reminder, we do have the question in the Q&A there, but just I'll read it again. Are there other aspects of aligning county behavioral health compliance reviews that DHCS should consider? I'm not seeing any feedback. I know this is a lot of material though to take in, and would love to have your thoughts, over the coming weeks. And so if you think of other ways, if you could just let us know. And as Michelle said, you'll see here we have a glide path, and we'll be checking in along the way as well. Oh, it did. After I just said that, we got a little feedback in for us to also look at where post-payment, post-service reviews, how that falls in to this process. It'd be great for DHCS to have some clarification around that. And then also just some feedback around the CHA and the CHNAs, if the reviews for those are aligned with these dates, to take into consideration that as we continue to develop this out. Also, a little feedback too about, I know what Michelle is describing here is the programmatic reviews, but then how does that align with audits? So for DHCS to take that into consideration also. All right, Michelle, I'm going to turn it back to you and we'll move to our next section.
Great. So I'm going to talk about the BHSA specific compliance review process. So let's go to the next slide, please. So the process that's outlined here follows existing Medi-Cal practices under BIN 23044 to the greatest extent possible. So any differences between the proposed BHSA policy and existing Medi-Cal policies are noted on the slides. So in alignment with Medi-Cal, the BHSA compliance review process will include 4 phases, including the review prep, live compliance review, post-review evidence, exit process, and the findings report. And the following slides will briefly note a few differences between the current MHSA process and the proposed BHSA process. Next slide, please. As under Medi-Cal, the BHSA compliance review may assess any program requirements that are defined under the performance contract, the BHSA policy manual, and state laws and regulations, including those noted on the slide. Please note that our compliance reviews will not focus on the fidelity of various treatment protocols to evidence-based practices. These will be assessed by applicable centers of excellence. Next slide. During the review planning process, DHCS will identify priority areas for each county based on county reports, the county's compliance history, and our assessment of member impact and risk. Similar to Medi-Cal, during the document collection phase, counties will submit required documentation in response to our pre-review information requests and documentation submission checklists. We will conduct a desk review to identify focus areas for the review. And we anticipate reviewing all topics at least once every 3 years, but some may be reviewed more often as needed, such as county-specific deficiencies identified by outstanding caps or statewide priorities. In addition, we will use our prior desk reviews to determine whether the county's live review should be conducted virtually or on-site, taking into account our goal for an on-site review at least once every 3 years. Next slide. So just like Medi-Cal, DHCS will interview key county personnel and review county documentation, which may include requesting additional supporting documents beyond those submitted in advance. We may also review provider services in client charts. Now, unlike current MHSA review process, but consistent with Medi-Cal reviews, the proposed BHSA process will generally not include discussions with contracted service providers, program visits, client meetings, or housing visits unless required. Counties will be responsible for monitoring their contracted providers, as described later in this presentation. DHCS will ensure that counties are monitoring their providers, but DHCS does not intend to directly monitor contracted providers for compliance with BHSA policies. Next slide, please. So as in Medi-Cal reviews, after DHCS shares draft findings, counties will have an opportunity to discuss them with us and submit a template expressing their agreement or disagreement. Counties can also submit additional comments or evidence to dispute DHCS's findings within 15 business days of receiving the draft report. And then we will review any of the post-review submissions and adjust our findings as needed. Next slide. So just like Medi-Cal, DHCS will also provide written findings report that details, what we found as well as required corrective actions. Historically, our findings reports and CAPs have focused solely on a particular program under review, but acknowledging that BH Transformation's goal, one of the main goals is to improve cross-program coordination and compliance. We're proposing that the BHSA findings report not only identify BHSA compliance deficiencies, but also emphasize any deficiencies that are common across Medi-Cal and SAMHSA funded programs to the extent feasible, basically based on our existing oversight of those programs. Some common issues that we might see would include access challenges, provider oversight issues, or documentation deficiencies. These commonalities will be particularly apparent as we move towards aligned reviews that address all programs at once. Next slide. So this third section of the presentation will focus on proposed administrative and monetary sanctions for the BHSA program. So next slide. So this slide shows the different types of enforcement mechanisms available if a county is out of compliance with BHSA requirements. DHCS will generally begin with administrative sanctions such as corrective action plans and required revisions to the IPAU prior to progressing to monetary withholds and sanctions, which are discussed in more detail on later slides. As a reminder, we will work collaboratively with counties on BHSA implementation, particularly in its early years. And as with compliance reviews, we are generally proposing to model BHSA sanctions policies on current and forthcoming Medi-Cal policies. Next slide. So this slide focuses on administrative sanctions, specifically corrective action plans. In alignment with current Medi-Cal practices, counties will be required to submit proposed BHSA CAPs within 60 calendar days of the final findings report. Then we will approve or request modifications, and counties must resolve CAPs within 90 calendar days of approval. We're exploring holistic monitoring methods for county compliance, eliminating duplicative enforcement in situations where there are identified similar performance deficiencies or similar CAPs across programs. In the early years of BHSA implementation, we're expecting to focus on training, technical assistance, and where necessary, administrative enforcement mechanisms like CAPs. We'll also ask for revisions to the IPs and AUs. These are considered administrative sanctions, but they are considered separate from CAPs. And as mentioned, counties may need to revise their IP or AU if they fail to address local needs or meet performance metrics. Next slide. So DHCS will be publishing BHSA findings, reports, and CAPs as required by statute. In addition, once counties adopt integrated Medi-Cal contracts, we will be publishing integrated findings reports and CAPs flowing from their integrated Medi-Cal audits in both DMC ODS and DMC counties. This policy marks a change from our current process under which we publish these documents for specialty mental health services. However, for DMC and DMC ODS, we are currently only publishing finding reports and not CAPs. Next slide, please. So now I'm going to discuss the Module 4 content on BHSA monetary withholds and sanctions. And as mentioned, the plan is to generally start with administrative sanctions such as CAPs or IPAU revisions. But for serious or persistent deficiencies on certain types of issues, we will consider escalating to monetary withholds and sanction. This slide outlines potential basis for withholds and sanctions, and then future slides will discuss the process for imposing or appealing those penalties. So our state statute actually explicitly provides us with the authority to temporarily withhold BHSA funds or impose monetary sanctions for the items that are listed on this slide. And please note that at this time, we have not defined the threshold for significant variance. but we'll develop these standards in future years as we gain a better understanding of how counties are allocating funding. With regards to IP stakeholder engagement, we don't anticipate significant compliance concerns since BHSA requirements are similar to existing requirements for MHSA. However, if we identify compliance issues while reviewing the IP as a first step, we would direct the county to complete all required stakeholder engagement processes, update their engagement processes, and then update and resubmit the IP. Generally, we will focus more on TA initially and then escalate before escalating to sanctions. Meanwhile, for the other 3 items on this list, can we go back? Thank you. So for the other 3 items on this list, we do not currently anticipate imposing sanctions until at least 2029, since we will be relying on the voter submission to assess compliance in these areas. All right, now we can go to the next slide. All right, so the next 2 slides actually are going to be laying out the details of BHSA withholds and sanctions, most of which are fixed in statute. These details are all modeled on Medi-Cal with one important difference indicated on the far right box. For BHSA, both withholds and sanctions must be returned to the county once the county comes into compliance. In Medi-Cal, DHCS must return withholds, but not sanctions. There's actually no statutory maximum for temporary withholding against the Behavioral Health Services Fund. DHCS is authorized to temporarily withhold any amount that we deem necessary to ensure the county comes into compliance. However, to increase transparency and avoid damaging a county's ability to deliver services, we wanted to provide counties with a maximum temporary withhold amount, and we are implementing a 25% cap on temporary withholds that aligns with the cap on monetary sanctions. Next slide, please. Monetary sanctions may similarly be offset against the Behavioral Health Services Fund, and under state law, the maximum sanctions escalate from $25,000 for the first violation up to $100,000 for third and subsequent violations, subject to a maximum offset of 25% of the county's monthly BHSF allocation. In cases where the full amount cannot be withheld in a single month, we will offset in subsequent months until the full cost has been offset. Next slide, please. In alignment with current Medi-Cal practices, DHCS will consider several factors when determining the amount of a monetary withhold or sanction, including the gravity of the violation, potential impact on clients, the county's history of violations, compliance efforts, and financial status, and the types of enforcement actions necessary to deter future violations. One new factor under BHSA, as noted, is that DHCS will consider the county's history of similar violations under other behavioral health programs and not just BHSA. Next slide, please. All right, so this slide describes notice and appeal rights for BHSA, withholds and sanctions, which are identical to current Medi-Cal processes. And in the interest of time, since these are identical to Medi-Cal, I'm going to go ahead and move to our next question for the group. So can we go to the next slide, please?
Thanks, Michelle. So are there other areas within BHSA that DHCS should consider identifying specific sanctions? I'm wondering, as folks think about that, is there a slide, Michelle, we can move back to? I think there was the one just a few slides back.
I don't think we have one specific, but these are the factors that we would consider. Let's see. Let's go to slide 40.
Thanks, Michelle.
Oh, wait.
That it?
That's not it. No, that is not it. actually. Slide 37. I think my numbers are off. Sorry about that. Let's try 36. I'm glad this is being
There we
recorded.
go. I think this is it. This is the one I
This
was
is the
thinking
slide,
about.
yes.
Yeah. We are getting some comments in, not so much around specific sanctions, but more around the timeframes there's some comments in about 2 days is a brief period to ask to meet. And then also some comments around just the timing to be able to receive and respond to once again in setting up the meetings. I'm not seeing a lot of input to our current question around the considering identifying any specific sanctions of areas that we should consider. Once again, though, doesn't have to happen today. If you have feedback, you can provide it to our inbox. That would be really helpful. So I'm going to turn it back to Michelle for the next section.
Great, thanks, Barlise. So we're gonna talk about the county level oversight of BHSA providers. That will also be addressed in Module 4. So let's go ahead and go to the next slide, please. So SB 326 requires counties to describe in their IP how they will conduct oversight of compliance of all federal and state laws and regulations of all contracted network providers. So counties have asked DHCS for guidance on acceptable monitoring protocols for their BHSA providers. And as a baseline, starting in state fiscal year 27-28, counties must adopt a monitoring schedule that includes periodic site visits and preserve monitoring records, which would include monitoring reports, county-approved provider caps, and confirmations of cap resolution. Counties will need to supply these records at any time upon DHCS's request. In Module 4, we are recommending but not requiring that counties monitor their BHSA providers under the same cadence as under Medi-Cal. Specifically under the integrated Medi-Cal contracts that all counties will adopt in 2027, counties must monitor at least annually for all Medi-Cal provider locations and perform on-site monitoring at least once every 3 years. We believe that aligning the provider oversight between BHSA and Medi-Cal will be the most straightforward approach for counties. And as a reminder, by July 2027, counties are required to ensure that most BHSA funded providers are participating in their SMHS, DMC, or DMC ODS programs in accordance with our previously released BHSA fiscal policies. Exceptions to this requirement may include housing providers and providers offering non-traditional services. By aligning provider oversight processes, counties may simultaneously then monitor their providers that participate in both Medi-Cal and BHSA, along with SubG or MAPG. In addition, the county could rely on BHSA monitoring of a provider that is performed by another county if the provider receives BHSA funds from multiple counties. This is the same as under Medi-Cal. In the IP, counties will indicate whether they plan to adopt this recommended monitoring approach to align with Medi-Cal for some or all providers. And if not, then the county must describe its alternative monitoring approach. Next slide, please. Finally, this slide addresses general standards for BHSA providers in addition to requirements defined in the policy manual for specific types of BHSA services. Counties are required to describe in their IP how they will ensure a network of qualified, culturally competent providers that comply with non-discrimination requirements. As with provider monitoring, DHCS recommends that counties align with applicable Medi-Cal standards with respect to minimum provider qualifications for licensure, certification, training, experience, and credentialing as applicable for the type of service, non-discrimination requirements in hiring and the delivery of services, including ensuring physical access, reasonable accommodations, and accessible equipment for people with disabilities, and providing services in a culturally competent manner. I do want to note that under state law, BHSA and Medi-Cal providers are already subject to many of the same standards on provider qualifications and non-discriminations. As for the remaining standards, we propose an effective date of July 1, 2027 to align with Medi-Cal requirements. And as noted, by that point, most BHSA providers should also be participating in Medi-Cal. Now, to support counties in adopting this recommendation, DHCS will be developing template letter language for counties' BHSA provider contracts and citing to applicable Medi-Cal requirements. Now, similar to what I mentioned on the previous slide for provider monitoring, okay, thank you. Counties can indicate their compliance with this policy by checking a box in the IP, stating whether they have decided to align with Medi-Cal standards for all BHSA providers or just for those that participate in Medi-Cal. Alternatively, they can describe their county-specific approach for ensuring provider qualifications, non-discrimination, and cultural competence. All right, now we can go to the next slide.
Thanks, Michelle. So our next feedback question is, are there additional standards for county monitoring of BHSA providers that DHCS should consider including in the proposed policy? We have some feedback here to consider the number of available providers in rural areas in comparison to other areas.
There's also a comment that we should consider guidance for supporting providers who will be navigating through the Medi-Cal certification process.
Great. Well, once again, feel free, you can still submit some comments until this webinar is over, or we can move to the next slide here. So I do just want to touch on that is the end of the material that we're going to be presenting today, but I did just want to touch on the resources that we have. So in case you haven't gone to our website, this is the link to our website where we have information on all of our policy. This is also where we have the county BHSA policy manual. If you haven't seen that, we have our modules 1, 2, and 3 are all finalized and posted. That's also the location once we are ready to release our draft of module 4. That's where that will be located. You can also sign up there on our website to receive information. We have a lot of infographics and FAQs, and those grow by the day. So if there's a certain topic there that you're interested in learning more about, I'd encourage you to visit that website. And then, as I mentioned, this is our inbox here, the BHT info. This is where you can provide feedback on this listening session today, or any of the information that you have questions on. You can put a question into there as well. So these slides, we are working on getting these posted to our website. Once again, that is where they will be located. We will also be posting this recording, so you're able to see it again, or send it to one of your peers if you want them to be aware of this information. We can move to the next slide. Great. Well, thank you so much. I do want to reiterate, if you have feedback to these questions, if you could get that to us by August 7th. And then once again, all of that feedback will compile. It'll take us a few weeks, but then we'll post that on the website as well. It's more general themes, but all of the feedback that you provide us will be reviewing. And then just keep a lookout as we use that feedback and continue to kind of craft out this draft guidance. Please look for it as we release the draft of Module 4 for public comment. Like I said, that will be out a few months, but we really have enjoyed reviewing your feedback. It's really helped us guide and change up the policy prior to it being finalized. With that, I just want to give a huge thank you to Michelle for your presentation today and the team. Excuse me. And for those of you that have been able to join us today, really sincerely want to thank you for your time. You've been really beneficial as we've been lifting up this really large effort in California. So with that, thank you for your service and have a great rest of your day. Bye-bye. Thank you.